So we'll move on, and we might have to sort of truncate our health breaks a little bit just to catch up. Our next speaker, I'm very pleased to introduce Dr. Andrew Beckett. Andrew has graciously parachuted in to fill in for Dr. Homer Tien, but brings with him a whole bunch of experience and expertise to discuss our next topic. Dr. Beckett is a Canadian Forces Health Services trauma surgeon. He served as the Canadian trauma surgeon at the Royal Free Combat Hospital in Kandahar Airfield in 2011. He has recently returned from Operation Attention, the medical training mission in Afghanistan. Dr. Beckett completed medical school at the University of Manitoba and then trained in general surgery at Dalhousie. He has also completed the Sunnybrook Trauma Fellowship Program and is currently enrolled in the University of Toronto Critical Care Program. Dr. Beckett will be presenting battlefield injuries. Dr. Beckett.
Well, thank you for having me here today, and it's a great pleasure to come in the place of Homer Tien, who's had other commitments that he had to fulfill today. And it's a great pleasure to be asked to come and talk about my experiences in Afghanistan. And but first, I thought I'd tell you a little bit about myself, how I got into this business. So I started out as I was a high school dropout. I grew up in Stouffville, just north of the city here, and I dropped out and joined the Army when I was 18, against my parents' wishes. But they put me in the medical corps as one of the combat medics. And I spent about 7 years doing that. In the early 90s, I was sent on the initial rotations into the Balkans. I mean, that's where I really got interested in improving my medical skills, and because we saw many people die there, and we could, with our level of training, could really do very little. And so that spurred my interest in going back to school and becoming a surgeon. So I guess that's where I grew up, seeing what happened in the Balkans and the war there. So the objective here today that Homer and I wanted to present to you is we talked about some of the psychological effects of war on children, but we're going to talk about some of the physical impact and the consequences of war trauma on children, and explore treatment options and outcomes. And let's say that children never start wars, but they often bear the effects of them and long-term effects as well. And I've talked to many people, and that their whole childhood was destroyed by war, and that they had so many opportunities missed, and they lived to regret these parts of their lives that they just could not have a normal childhood. And especially the children that are wounded by injury and then suffered because of inadequate medical care. It's a tragedy. So Homer and I, we really don't have any disclosures to address, but this is his standard slide, and I don't have any disclosures either. So mechanism of war include blast, bullets, fragmentation, burns, etc. And we'll look at some of the injuries and how they're caused and the treatments and consequences. So blast injuries, blast is what you see on the movies, and I remember some of us growing up in the 80s, you'd see a bomb go off on the A-team and everybody's sort of thrown out of the way and nobody gets hurt. Well, that's not reality. This is what a blast looks like. This is some of the training videos that we see before we go overseas, and this is a Soviet armored personnel carrier in Afghanistan traveling along a mountain road, and a bomb goes off, and then you see fragments and personnel being thrown away from the vehicle, and then you see this burning hulk of a vehicle after its destruction. So that's in Afghanistan. Certainly, this is probably very similar to what happens when one of our vehicles is struck by a roadside bomb. Landmines. Ottawa signed the Anti-Landmine Treaty Agreement in 1997, and landmines, Afghanistan is one of the world's highest concentration of landmines, and just scattered all over the place there. And there's been no active demining operations been going on there. And also in Cambodia, Vietnam, there's still a high prevalence of landmines. And these are a significant risk to children and to families trying to reclaim land for farming. So landmines themselves, anti-personnel landmines, which is just shown here, are not designed to kill people. They're designed to maim people and take people out of the battlefield. And tactically, minefields are used to deny the enemy access or make the enemy go in a certain way so you can ambush them, etc. But they're really not designed to kill people. They're designed to maim people. And because the thought is that somebody like this, they'll be taken out of the battle. It'll take two people to carry him, and the medical burden he puts on the medical services and the transport requirements and the effect on the population when he gets home. And that's why mines are designed just to maim people. Mines, there's been a lot of trials in trying to understand how mines actually work and damage human tissue. And what they did in Suffield, Alberta, is they've designed simulation models to see actually how mines work and impact the lower extremities, and to design better ways of protecting the soldier or personnel. So they set up this thing where they have X-ray film and a sample limb with a boot on, and then try different types of anti-personnel mines. So this is basically what you have a boot there and a mock limb, and this is basically what's left after a landmine goes off, and this is basically the stump that's left. And you see this many times in Afghanistan, and I'll just go back there for a second. And the issue is that not only is this tissue destroyed and going to have to be debrided and excised and amputated, is a lot of the tissue that even up higher is completely destroyed, requiring a much higher amputation. And that's why in the developing world, where there's a high prevalence of landmines, there's a really strong need for good prosthetic limbs and good prosthetic limb programs to treat children who continue to grow, continue to be active, and they need a continuing prosthetic limb program and rehabilitation program. But unfortunately, in many of these countries, there is no such entity. So blast injuries, which cause a lot of these injuries, they can be broken down into four phases or four types of injury. The primary blast, which is a hyperbaric injury, is an overpressurization of tissue. This could be exampled, for example, after being exposed to a large blast, there can be rupture of the tympanic membranes, and also people are exposed to what's known as blast lung, or bruises of the lungs, just because of the high pressurization changes after a bomb. The secondary blast is the fragments from the bomb, or things thrown out of the bomb. In Afghanistan, the improvised bombs, they'll put anything in there from ball bearings to bits of rebar to nails, anything really to cause fragmentation injury. The tertiary blast is blunt trauma from the vehicle rolling over, from persons being thrown against something, and the quaternary blast injury is all other things, including burns, including the building collapsing on top of you, etc. So if you can see in this diagram, this is actually this high-speed photo. You can actually see the shock wave from the blast, which is, you can almost see it up here. I'm not sure how well projected, but this is the line here. And actually, that's the shock wave of the blast moving forward ahead of the explosive products, which contain fragments. And this shock wave causes effects on your tympanic membrane and can damage your internal ear structures, or the little bones that make you to hear sounds. So fragments, these are some fragments recovered from bombs, ball bearings, little bits of metal, all kinds of little things. And this is what is here. This is bioshrapnel. This is what effect when there's multiple casualties from a bomb, and pieces of bone from other casualties can be projected into other people. And we had this young fellow. He was riding on the back of a moped when they hit a bomb, and it was actually the patient was a 10-year-old, and his brother was the driver of this moped, and the driver's about 16, I think, and the driver's head was blown apart, and the child was blinded by fragments from his brother's skull. So that's a bioshrapnel. So these are types of wounds that you see from a blast from an improvised explosive device, just multiple fragments. The biological fragments I was talking about, you can see here, these are bits from a foot driven into somebody's limb. And again, we saw this one of the blast. This is the tertiary blast where people are thrown against things, the vehicle rolls over, etc. Quaternary blast, as I was saying, the building collapses, there's a fire afterwards, or there's toxic inhalation from the components of the bomb, or fires afterwards. Projectiles, they come in multiple shapes and sizes. But the thing was, when we were dealing with bullets, and over the weekend, yesterday, as most of you probably heard, there was a shooting down at the Eaton Center. When we're dealing with shells, with bullet wounds, people get very excited, in terms of, well, it's a high velocity firearm, or it was a low velocity. Surgeons, we're trained to treat the wound and not the weapon, because really it's about the delivery of energy. And as we all know, this equation is half mass times velocity squared. So it's really the amount of energy being carried by the bullet. So it's a big difference from a bullet that was fired 2 kilometers away versus one that was fired from point blank range. And so it also matters the distance, how heavy the round is. So there's a lot of playing factors. So we really try to treat the wound and not the weapon. And these are just some representative energies from different types of missiles. This is the one that we would use, 5.56 millimeter NATO round, and it carries about 1,600 joules. And that's compared to an AK-47, slightly bigger round, and it's 2005 joules. But you can tell these are at the muzzle velocity that carries at the point of exit from the weapon, but as you get longer distances, the velocity is much less, and so you really have to you deal with the wound and not the weapon that is self-carry. But you can see just the evolution of firearms from a flintlock carrying very little energy to per millimeter squared to a 5.56 NATO round carrying a lot of energy within that missile. So Homer's done a lot of work on this, and we talk about the permanent versus the temporary cavity. And what this CAT scan is showing, this is showing the permanent cavity. You can see a lot of times when we're looking at wounds, you can just see the little bubbles of air where the missile has traveled through tissue, sucked in air with it as it travels, or in here through the lung. This is a permanent cavity from a wound. So there's 3 phases. There's usually a narrow entrance point where the bullet hits the end first, and there's a larger cavity as the bullet mushrooms out and tumbles, and a narrow exit tract. And so this is what it looks like. Many gunshot wounds, they're actually that small and they can be quite subtle. But as they enter the tissue and the energy is delivered to the tissue, they open up this larger cavity, and the bullet will actually turn on its side as it travels, and I'll show you a diagram of that later. And afterwards, you get little fragments coming out. So in terms of a ballistic cavity, in military settings, it's been agreed on that rounds should be full metal jacketed rounds, and this is to decrease the morbidity and undue suffering caused by some other types of rounds. So they're either have a steel or copper jacket, and they have a lead or steel core. And so this is what happens. This is what I was talking about, the permanent cavity. You can see the missile enters here, and it travels along, and the bullet will turn on its side and tumble through the body, and then it will keep tumbling, and then it will actually leave the body as a small exit hole. So you can see different sizes and shapes of the permanent cavity. The temporary cavity is what happens is most of us are made of almost all water, and most of us, some of us are made of mostly alcohol, but And so you can imagine if you drop a pebble in a pond of water, you see this rippling effect, and that's exactly what happens when a high velocity or any type of projectile strikes human tissue. You get this rippling effect of a shock wave going through the human tissue, where the ripple will spread outwards, and the tissue contracts outwards, and then it collapses back inwards. And both the compression outwards and the collapsing back inwards, it causes tissue damage and tissue tearing. And this is called the temporary cavity, which is not there. But as you go and explore the missile tract, you can see extensive tissue damage around where the permanent cavity is. So types of injury, and in terms of summary, is there's multiple mechanism injury, overpressurization, fragments, including biological fragments, blunt injury, and very severe injuries. And military gunshot wounds, they can be high velocity and carry a lot of energy, and they can cause very large temporary cavities. And I will say one thing about blast injuries, which if you ever are working in a setting where you going to have patients coming in exposed to a blast injury, especially from a terrorist attack or from a large missile attack, is there'll be people coming in and they'll look fine, and they're really the only signs that they've had exposure to an overpressurization event is from they have perforated tympanic membranes. You have to be very careful with these people because within a matter of hours they can develop severe respiratory distress and wind up on ventilators because they develop blast lung or pulmonary contusion. It takes a little bit while to develop, and they can be on very high ventilator settings within a matter of hours. And we certainly saw this in Afghanistan after a number of attacks. There's other nasty things out there that people use. There's other stabilized projectiles, and this is a flechette round. And it's obviously a very nasty looking thing, and these are used in anti-personnel, especially for massive ground attacks. So there's lots of interesting ways to develop weapons and kill people. Unfortunately, in the medical side, we have a hard time keeping up with all these things. So I'm just going to talk a little bit about Afghanistan and my experience there. Afghanistan, it's not a nice place to grow up, and they have the highest risk of death in the world. Just looking at, in terms of life expectancy in Afghanistan, for men it's 42 years of age, for women it's 44. And I've talked to many parents of children there, and many of them have lost 4 out of their 8 children. And they're very accustomed to losing children in that part of the world. Maternal mortality there and female life expectancy is the lowest in the world. And in perinatal issues there, it's just incredible. And a lot of the issues surround sort of the cultural beliefs about the worth of women. And they had a saying in that area that from some of the Pashtun area saying that women should be in the home or in the grave. And so I think there's a long way to go in terms of addressing the rights of women in Afghanistan, obviously. So there's many child fighters in Afghanistan, and many children get involved in the insurgency against their will, or they have no choice but to join. Just a couple of cases. In the Role 3 hospital in Kandahar, we almost have a whole ward of children, and they're allowed one, it's usually a male chaperone to stay with the child there. And many of the children come in, and to be honest, I'm not even sure how they come in. They're selected to come in. There could have been some collateral damage from an ongoing NATO mission, or somebody just may show up at one of the forward operating bases with a wounded child, or maybe there was a patrol and saw a sick child and they decided to bring to us. But anyways, we do our best to look after all these children. And despite the fact that besides our normal training and residency, I really cannot claim I have any pediatric expertise. So anyways, this 12-year-old boy is hit in the head with shrapnel from an improvised explosive device. His GCS is 12 on admission, which For people who don't know what it is, it's the Glasgow Coma scale, and it's basically a 15-point scale. So GCS of 12, it means this person's a little bit confused, a little bit groggy, and he had ongoing signs of losing consciousness. And his right pupil became dilated, and this was in 2006 before we had a CAT scanner there. And so the plain film x-ray was done. It shows a piece of shrapnel just underneath the skull. And craniectomy was done with evacuation of subdural hematoma, removal of the fragment. And the patient improved neurologically. Unfortunately, the patient had left-sided hematopoiesis due to the piece of fragment hitting his motor area of his brain, and he was discharged home. Now, discharge home in Afghanistan doesn't mean you're just repatriated to your local hospital or your rehab center. It means you go home with your family and whatever they can give you. And this is probably not an uncommon consequence, coming back a month later in septic shock and dying. Case number 2. Afghanistan, children have to do many dangerous things there. And they're often tasked to do things like filling lanterns when they're 5 years old that they catch on fire, or filling generators like this boy did. And he suffered third-degree burns, about 50% of his body, and he eventually succumbed to his burns. Just want to point out here, this is a tapeworm, and this is taken out of one of my patients, a 12-year-old girl. She had been had intra-abdominal wounds from a grenade thrown by the Taliban into her family's house, and we deworm all the children coming in because many of them carry parasites. This tapeworm was about 2 meters long, so I mean, just the level of health markers for the children, tend to be very undernourished coming in for parasites, lack of nutrition, etc. And that patient T eventually succumbed to his injuries as well. So, number 3, this patient T was an 8-year-old boy. He threw a bomb he found at the side of the road. He threw it at a donkey to see what would happen, but unfortunately it exploded, and he became a triple amputee, and eventually he was repatriated home with his family. And it's difficult to say what kind of life he would have in Afghanistan being a triple amputee. This is a 22-month-old child, a patient of mine, who was shot in the head during a crossfire. So this is an AK-47 round. And this is the CAT scan of the child's brain, so transhemispheric gunshot wound. This child, actually, we did a craniectomy on the child. We removed the bone flap. We were able to remove the bullet, which is sitting about here. And the child was having persistent seizures. We discharged the child home with the family with appropriate anticonvulsant medications, but it was told to us that the family on the way home, they took the child off and left it in the field and kept driving. So, I mean, it's a question, should we be saving children like this in this type of environment? So there's a lot of ethical problems with treating these children and what's going to be their final outcome. But of course we do everything to save the child, and we get them as good as we can. But there is no rehab center to send them. There's no extended care facilities. This is it. This is the best treatment they're ever going to see. This is a child that was the Taliban were using a compound as a staging base, and there was a firefight developed and resulting in fire in the building, and this child sustained probably about 55% burns, which then sort of evolved into, initially we thought it was about 55, so we thought we'd give the child a chance and see if we could get them through it. And the child eventually declared themselves about 65% burns, and the back was all burned as well. And the child actually developed renal failure, and there's no dialysis capability, especially pediatric dialysis, and the child succumbed to renal failure. This is a a case. This is little fellow's name is Hassan, and this is actually his uncle. And this is his uncle who was telling me he had lost 7 of his children during the wars in Afghanistan. But this little guy, he was on Christmas Day, on New Year's Day, 2011. He was shipped to us with a blast wound from a bomb, where his one of the main arteries in his thigh was severed, and we repaired that. He has a bunch of intra-abdominal injuries. It was a very busy day in Afghanistan, and our camp was under a rocket attack, and we're seeing multiple casualties for that. So we missed an injury on the child, and he wound up having a complication from that and staying with us for about a month. So we got him through it, and we got him to know him quite well. And he was singing a song one day, and I asked the translators what the song was, and they said, "Oh, it's nothing. It's just a song he's making up, and it doesn't really mean anything." So, "Oh no, what is he singing?" And so the song was, he was singing a song saying, "I have dug my grave and I made my headstone, for I was ready to die, but now I am better, but I have put my gravestone away for now." And I think, it's kind of revealing just the way that children think in this area, that they're so accustomed to death that they're ready to die, and this is on their mind all the time. And if that happened in Canada, we'd probably be consulting social work, etc. But it's just revealing how they think. And the other thing I noticed about children in the ward there, that when a sick child comes in, they're injured, everybody rallies around the sick child, there's lots of toys that people send over for the kids. But as Dr. Baum was saying, these children do not know how to play. You give them a toy truck, or they have no idea what this is, and they just don't want it. But it's how resilient children are. After a few days with this, or after a week or something, they start playing with it, and so they are really resilient, and they can bounce back to some extent from their lives. So, just in summary, we're developing more and more devastating weapons as a race, and also we're very good at destroying infrastructure, and we're very good at creating critically injured people, but we're still not good at caring for people always, and especially children. And children are very much an afterthought of war. And we never really have a good idea how we're going to treat these children of these wars. The psychological effect, a lot of people ask, well, how does this affect you? And I think many of us in the military have children, or we have nieces and nephews, or some of my colleagues are even grandparents when they go over. But it has a tremendous psychological impact on people treating these children. But even we're great in the acute care with these children, but we're sending them back to an environment where there is no aftercare, and this is the end of the road for them. So, and I have no follow-up data on any of those children, so it just leaves a question mark of, did we do the right thing? And I hope we did. Thank you for your attention.
Thank you very much, Andrew, for that incredible presentation, very eye-opening and sombering. We are running quite late, so we'll have time for one question for Andrew, and then I think we're going to, I know Senator Dallaire has a flight to catch, so we'll make the health break a little bit shorter than we anticipated.
On behalf of DARA, I'd like to present you with a certificate thanking you for your parachuting in and for your wonderful presentation, which opens the eyes of many people about what a fortunate environment we live in, especially when compared to the rest of the world. Thank you very much.
Thank you, Dr. So I think what we'll do is we'll now take a 5-minute break, and if anybody has any questions for Dr. Beckett, I'm sure he won't mind sticking around for that. Thank you. We'll move on to our last speaker. Dr. Frank Summers, known to many of you here in the audience. It's a pleasure to introduce Frank, who I've now known for, I can say, for several years. Frank Summers is a psychiatrist specializing in the treatment of marital and sexual problems. He's an award-winning pioneering researcher in the application of audiovisual media in service of his therapeutic practice and teaching. He's a former member of the medical faculty of the University of Toronto and served with the Two-Field Engineering Regimen, RCE, as a corporal instructor in the early 1960s. As a psychiatrist, he served with the Canadian Forces at the Royal 3 Hospital in Kandahar Airfield, Afghanistan, in late 2007. He's an author, a filmmaker, as well as an honorary and founding president of Canadian Physicians for Social Responsibility, and was a founding council member of International Physicians for the Prevention of Nuclear War, who received the Nobel Prize in 1985. In 2008, he was elected a Distinguished Fellow of the American Psychiatric Association in recognition of his significant contributions to psychiatry. He's also, of course, an executive member of DARA. Dr. Summers.
Thanks, Jeff. It's not easy to follow Dr. Dallaire's very moving presentation of issues which are concerning many of us today. And I would ask your indulgence, because it's the first time that I'm talking in my lifetime in a public audience about some of my personal experiences that have affected me and my family. So I guess it is my disclosure, as you can see. And then let's just, this is a minute or so, if we can run this very quickly, maybe I'll let you do it. Just to give you a little flavor of that could have been. Thank you. So these are numbers that I assume most people here know, so we won't dwell on these things. These numbers. I had occasion to visit Majdanek extermination camp, and has anybody been to one of these extermination camps? Many of you have. So the unique feature for me was I was there in 1982, end of August. I was the only person walking through the camp. I was at a meeting in Warsaw, and it was very eerie. Maybe it's a different experience when you're walking with others, but it's a searing experience. So this is our past. I was born in Budapest in 1943, and Hungary was an ally of Germany, as many of you know. part of the Axis, so they didn't occupy Hungary until when they were in full retreat in 1944 March, and that's when the final question for the Jews started to become top of the agenda, even though everybody knew that Germany was finished. If we just quickly run through that, you can see that there was a population of 200,000 in the city of Budapest. It didn't save anybody who converted, by the way. A lot of people did try to convert. And very efficiently, within a matter of 4 months, vast majority of the Jewish population of Hungary was eliminated. We were among the bottom group, I guess. This our family, except we occasionally found some shelter here, but we were also on our own in some of the buildings, bombed out basements that you saw there. This is the river Danube. Anybody been to the city of Budapest? So you walked along Danube. Well, this is where people were brought in for a swim. And as General DARA mentioned, nothing is more dangerous than giving a 10, 11, or 12-year-old Kalashnikov or a submachine gun. And many of our family ended up, and many of others' families ended up executed. And those bombers you saw were actually Allied bombers coming over the city, and American flyers mostly. And so every evening at 10, apparently, they were taken down to the cellar as the air raid shelter. So this is a partial list of some of our immediate family who we don't know what became of them. We never found, of course. And this is a memorial. There's 18 names there, and again, it's a partial list. So we were robbed, and that stays with us all through life. And I don't think anybody has mentioned that yet this morning. I still feel robbed. So this is how we escaped. It was a bare survival existence. Potato peels, scavenged from garbage cans. Our grandmother tried to prepare that for us. Water melted from snow. Living like animals. Very close call once when some of these marauding Nazi Arrow Cross youth came by and started to search for hiding Jews. Luckily, we were saved by some firing which happened outside, and they rushed out. And one of them left their glove behind. My mother picked it up, ran after him, and maybe that's why they never came back to follow up their search for us. It's amazing how little things can sometimes determine whether you live or die. So this is the city, and I think there's a starving horse there. And I was talking to my brother the other day, and he actually remembers going out with my mother, and when they were searching for food, and seeing people cutting horse flesh. You do strange things when you're starving. Now this is my first memory, emerging from a dark basement, and it was the Red Army soldiers. I quite clearly remember that, the man and a woman, and a motorcycle and a sidecar. And that's my first emerging from the darkness of our hiding place into the well-lit courtyard of the building where we were hiding. So after this introduction to life on this planet, I had the privilege of falling into the darkest days of the Cold War, of course, along with my family. I'm just using myself as an example and millions of others. And in this case, it was the secret police and their activities which terrorized us. You can see some of the details there. In a climate like that, one learns to be extremely cautious. And fear is rampant and palpable. Our future was going to be not very pleasant due to our background. Personally, I also experienced severe episodes of intense pain, repeated myringotomies without any anesthesia, and back then, so that wasn't, that was just an added burden. Then, of course, as earlier mentioned, at age 13, on the way home from school, I ended up with thousands of others in front of our parliament buildings demonstrating for some measure of freedom. And these are pictures from there. And as you may know, this ended up to be crushed by the advancing Soviet armies this time on November 4th. So this enabled us to make our way to freedom. We tried twice. First time after 2 nights walking in the cold, because we couldn't walk in the daytime for fear of being discovered. This was through lands. We ended up being captured, and then we had a second attempt, as you can see, successfully, a forced march, and that's the only reason that I'm standing here. It's amazing how sometimes you can pinpoint your turning point in your whole life to one particular moment, because we made it. So then we began life of the refugee, and starting to study English, taking the boat over here, and I clearly remember that day, February 11th, 57, 6 in the morning, when our train pulled into the Union Station from Halifax overnight, and it was bitterly cold, snow on the ground, but our hearts were warm. We have arrived in paradise, a new home. So that's just one person's journey. A year and a half later or so, our grandmother was able to come out legally due to her age. They let her go. And that's a little family picture of the survivors. These are the 7 people who were crammed into that little room during that period from September to January 1945. So that's those are my markers. It's enough. Enough for a lifetime. I did go to Afghanistan to help out because there was a shortage of psychiatrists, and I felt a need to try to help out. I believed in what we're trying to do there. And this is just an example of my little contact. I became very friendly with this little 12-year-old boy, Ahmed, whose foot was blown off. And I remember asking him, do you go to school? And he laughed at me and he said, to school? The Taliban have closed all the schools 2 years ago. I'm the village tailor. And he said proudly. You know, little kids like this, as I became to know him, are smart. They could become anything if there was a peaceful environment there. And they wouldn't have to turn, in other contexts, into killing machines, because that was their way of survival. So let's just run through this. I know time is so it's going to be fairly quick, but it just follows up Roman Delera's comments. 1 billion children living in conflict or emerging from war. It's horrendous numbers, and 300 million under 5 years of age. Now, this is the other issue that I think Romeo referred to. You can see that the civilian casualties, the boundaries are really being eroded. So these are the consequences, as well known, the direct trauma, starvation, infection, and then, of course, displacement and disease. And I quite agree that those who survive don't necessarily are survivors untouched. We all have sequelae. So, psychological consequences, obviously, anxiety, depression, PTSD, and the prevalence does vary. We're not all equally susceptible. And there is the numbers for Rwanda, for example, on one of the studies. This is just one suggestion. When people, we tend to feel powerless when we see these kinds of things and wonder, what can I do as one individual? Well, we can do more than we sometimes think. Just as an example, when I began organizing doctors in Physicians for Social Responsibility in my home in 1979, it was thought that the nuclear issue was much too complicated for ordinary mortals, just regular doctors. It was a subject for generals and diplomats and so on. And it really amazed me how many generals actually learned from us about the medical consequences of nuclear war, and how many politicians learned from us. When I was asked to testify at the House of Commons Committee on National Defense on the medical effects of nuclear war, the committee members were astonished. They had not heard that testimony from anybody else. Pierre Trudeau himself, as we became friends, and he became educated on this issue, they don't know. They don't know what we know, folks, or they don't want to know, but when we confront them, they're willing to listen. So let's not disempower ourselves. Okay, if we had more time, I would go more into this, because this was during the Nazi occupation of Holland. And 60 years later, there's documented evidence of these, as you can see, these sequelae. Okay? This is 60 years later. So here is, this is another famine study from China. You can see that there are impacts, but I want to get to some of the mechanism, so I won't belabor this. How does early life stress get under the skin, and can early childhood adversely imprint on their chromosomes? This is new research, and probably most of us have not too much familiarity with this. So, telomeres. This has now been documented, and it's quite amazing. Even though these children were, as you can see, not war trauma exposed, they had other kinds of trauma. And lo and behold, look at the results. Telomere erosion, that seems to be a mechanism. So this seems to lead to this reality. And this is still fairly fresh research. Long-term sequelae. Again, we studied impact on Toronto children of the nuclear threat, as some of you may remember. And war and peace certainly was the first issue. So children do react to these things. So these are some studies from other war-related areas. There is one here from Gaza. And as you can see here, so these studies are coming out. But, of course, as you heard from Naomi Baum, we have considerable literature now coming out from Israel, from both sides. Children are children, and they're suffering. Second-generation survivors. Actually, Ida earlier asked me about that, but I think she had to leave. So this is a controversial bit of an area, but you can read the results there for themselves. And so 3 themes there, as you can see: focus on survival issues, lack of emotional resources, and coercion to please the parents and satisfy their needs. So this is debatable, coercive or self-coercion as opposed to external coercion. A whole session could be spent just on that. So this is kind of interesting, isn't it, that these impacts last. These are some of the intervention studies. Group crisis intervention can be helpful. I have to run through these, folks. I'm sorry, because of shortness of time. Rapid intervention obviously is important, but the right kind. This is a schema that I put together when I was working with the soldiers because I didn't want to drug them due to acute situational anxiety, and yet they couldn't operate fully, either in the state they were in or if I put them on medication, there would be undesirable side effects. So I started to teach our padres how to apply this method of stress immunization to them. And it's essentially a mindfulness technique. And I'm happy to say that it really was very effective to them. We put it in the form of a soldier's card. So we need to know about, when we look at these issues, about the risk, the resilience, how to engender it, reinforce it, what is the nature of the trauma, its length, and what is the milieu among the immediate caretakers. Naomi Baum very well emphasized that, the importance of that. Supportive structures, very important. Professional supports. So in 1999, we had a little trip, family trip, and this is my brother and I at the place where the border is between Hungary and Austria. This is where the barn was where we hid from. After we were captured, we were in hiding for a few hours before we were discovered. And this is the building where we lived during the war that we actually went out from with my mother, who is no longer with us. And you think this is all over? It's not. This is from today. This is from today in Hungary, one of the signs. And in Hungarian it says, Hungary is not for sale. There's no substitute for vigilance. And as I said earlier in the annual meeting, we all have to be sentries. And DARA is one of the few organizations, professional organizations, that is trying to fulfill that task. So, this is the new generation, I'm happy to say. Our sons, my brothers and I, standing in the same place where we stood in fear and cold on a December night. And this is a straight line. So let me just share with you that fear, anxiety, insecurity, hopelessness, a sense of what's the use, and depression doesn't go away. We can manage it, but it doesn't leave us. And it's always lurking in the background. Food insecurity. You know, I get anxious when I'm not near some source of food. I don't have to eat all the time, but I have to have a sense that food is available. Guess what? This is food to go. It may stay in my pocket for quite a while, but it's good to know that it's there. Frontal lobe modulation has to override some of these things that are happening down in the amygdala. And I can say that freedom for me is not abstract, but palpable, concrete. And I'm trying to use the creativity that it fosters to contribute to those who don't taste, smell, and feel it the way I do. One of my strongest feelings is that no ideology, no government has the right to inflict on children the kind of nightmares that I had to experience at the height of the Cold War. I respect life wherever I find it. And that respect compels me to seek dialogue and to seek ways of accommodation that affirms life of dignity, life and dignity. Thank you for your attention.
Thank you very much, Frank, for sharing such personal emotions and experiences with us. Sorry, we're going to draw to a close in a moment. I just want to make a couple of comments and some thank yous. I have to mention our corporate donors who have very, very generously helped sponsor this morning's event. So thank you very much to Abbott, and I think Covidian is another one. And there's thank you. They are listed on the back of the program if I've left anyone out. This morning's talk was really to learn about this horrific phenomenon of children being involved in war, both as soldiers and as victims. And we have, I think, learned a considerable amount, but it's really not enough just to learn. It's, as I'm sure all of the speakers will agree, it's important to get active. And as a consequence, I just wanted to announce that DARA is going to be making a donation, substantial donation, to the Lieutenant General's Mission Child Soldiers Initiative. And I think hopefully this morning will inspire you not just to learn about this awful phenomenon, but also to become active and use DARA perhaps as an example to follow suit. On that note, I would also just, before I completely close, remind you that if you're looking for CME credits, you must submit your evaluation forms at the end. So with that, I would like to close by thanking our speakers, Lieutenant General Dallaire, Dr. Summers, and Dr. Beckett, and of course Dr. Baum, who joined us by Skype, sort of. Thank you very much.